Hello, and welcome to the NETEC webinar series. Today, we're going to be talking about influenza, a 2022 seasonal update. I would like to say good afternoon to my friends on the East Coast, and good morning to my friends on the West Coast, and good mid-morning to the people in Middle America. Okay, so let me introduce my friends. We have Dr. Gavin Harris. He's an assistant professor of medicine at Emory College. We have Dr. Anna Yaffe. She's a physician and associate professor of emergency medicine, and she practices at Grady and Emory. She also works as an SME for NETEC. We have Aileen Patel. She is a nurse with a master's in CCRN. She's the project manager for the Center for Disaster Medicine at Mass General. She also supports the Respect at Mass General. We have Jill Morgan, a nurse and site manager for Emory University, and myself, Trish Tennell, a nurse, associate director of nursing at H&H Bellevue, where I'm their nurse lead for special pathogens. Remember, at the end of the presentation, we're going to give you all the NETEC resources that you'll ever want, and also you'll be able to pose any other questions you have to NETEC at info@netec.org. But we'll go over that in the end. So this is the NETEC mission, one of the most important things. NETEC sets and advances the gold standard for special pathogen preparedness and response across the healthcare delivery systems with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. Again, for more information, go to netec.org or email us at info@netec.org. So NETEC has 3 areas of focus, but now we have 4. And let me tell you a little bit about our 4th one before we get into the 3 up here. Our 4th one is an international arm. This international arm allows us to share best practices that we have throughout the United States with our international community. And they're able to share their best practices with us. Special pathogens is now global. You can get anywhere within 24 hours. So it's helpful if we share these practices. And we're excited to share them with you. So watch for more information. Our other 3 arms are consultation. We're able to help you with readiness consultations. We can do an on-site assessment. We can do a remote assessment. We also have emergency on-call mobilization team. Education, where I'm an SME. We used to deliver in-person courses, and we hope someday to get back to that. But right now, we provide self-paced education through online trainings. We have a repository that you're able to get templates for any SOPs or skills you may want to do. We also have customizable exercise templates. One of my favorites is the Secret Shopper. Quick, easy, can be applied to any facility, any department, and you're able to make this your own. And we also now have a research network. We have a central IRB process. We develop policies and procedures and data capture tools that we're able to share with people throughout our community. And we're now creating a specimen biorepository. All 4 of these arms talk to each other. And if we find a need, we're able to bring that to a different section of NETEC, and we're able to help you. So please feel free to contact us. I'd like to introduce you to Dr. Gavin Harris, who'll be talking about the current U.S. influenza SITRAP, trends and managements and considerations. Dr. Harris?
Thank you so much for that introduction, and welcome to all the panelists and to the audience as well. I'm just going to first introduce how we monitor and predict influenza activity here in the United States. And I want to do that just so we have some frame of reference going forward. Weekly influenza surveillance is performed in 5 different categories and compiled from 9 different data sources, each utilizing different means. And it's ultimately combined into what is called FluView, which is an interactive application that can be freely accessed on the CDC's website. Now, data gathering itself is a collaboration from many partners from the local level to the international level to determine several things: where activity is occurring, which viruses are circulating, if there's been any changes or shifts in these viruses, and to measure the impact not only on mortality, but also on healthcare capacity. And I surely don't need to tell this audience how important it is to perform this surveillance, given the propensity for flu viruses to change, which in turn alters our public health response. So historically, this is when flu activity has typically peaked in the United States. And this is data that's compiled from 1982 through the 2021 flu season. And you will note that flu activity typically peaks in the Northern Hemisphere in the winter months. We'll talk about this more, but February overwhelmingly. Importantly, during the 2020 to 2021 season, there was no peak because there was uncharacteristically low levels of influenza virus circulation at that time. But you can see here, and this is data that is current through last week, flu activity is extraordinarily high already, especially in the Southeast region. And you can see purple reflect very high influenza-like illness, which we will discuss in a moment, activity. And this is highest in states such as Alabama, South Carolina, as well as Tennessee. The northern parts of the country have not yet peaked in terms of their activity level, but all throughout the country, we seem to have already flu activity in October. Now, as many of you may know, there are 4 different types of influenza viruses, A, B, C, and D. Human influenza A and B viruses cause seasonal epidemics, and influenza A viruses are the only influenza viruses that are known to cause pandemics as of yet. And this is important because it affects our management both at an individual level and also for population-based medical countermeasures. C viruses generally cause mild illnesses, and D viruses are not known yet to infect or cause illness in people. As you can see on this graph, the overwhelming majority of influenza virus this season has been of the A type and H3N2 subtype, with some circulation of influenza B virus happening already as well. Here is largely a pictorial representation of the previous data, but it does elucidate the general trend of the Northern Hemisphere flu season, which actually started quite high and surprisingly in May, decreased in the summer months, and now seems to be picking up again quite early. The data for the most recent weeks has not yet been fully compiled, and that is why it appears to have a decrease. And I expect this trend actually to increase. Now, these 2 graphs to me are quite illustrative. On the left is a total percentage of outpatient visits for influenza-like illness that begins this year in week 40 or the first week in October. Now, influenza-like illness, or ILI, is defined as the presence of fever that is greater than 100 degrees Fahrenheit, in addition to cough or sore throat in the absence of an alternative cause. But keep in mind, this can also be due to things like RSV, enterovirus, COVID, among others. And flu typically only causes 25 to 30% of ILI in a typical season. The important piece here on the left, though, is that outpatient visits are the highest they have ever been since 2017 to 2018. And the reason I use that year is because that year was the most severe seasonal epidemic of influenza this country has ever experienced. But you can see currently we are already outpacing that much, much earlier. On the right is data separated out by age group, and those currently most affected are our younger pediatric groups and young adults. But you can see all age groups, and most concerningly, those in the older age groups, are rising already as well. Now, my background is actually in ICU capacity planning for mass casualty events, and this graph is extremely concerning to me. So again, if we plot hospitalizations for just confirmed influenza, which is what this graph shows, we are already way above the curve here from that peak in 2017 to 2018, and only a few weeks into this current influenza season. Interestingly, you can see that the bottom dark blue line here is almost flat. That reflects the minimal influenza circulation last year. So these are all warning signs that we are following quite closely. Now, by comparison, we are also experiencing a surge in adenovirus cases nationwide. Adenovirus can cause similar influenza-like illness. The important piece of this graph is the middle bluish curve, which represents PCR detection of the virus in samples. And you can see that that curve continues to increase throughout October and continues to go up now. Now, at the same time, we are also experiencing a respiratory syncytial virus, or RSV, surge. And here, a similar graph, you can see on the left, percent positivity and detections on the right. Now, data for the most recent 2 weeks has not yet been confirmed, but the trends continue to rise rapidly. The middle peak that you see on those graphs represents the time period of May and June, where there also were surges earlier this year. So to summarize, currently right now, Region 4 and Region 6 in the southeastern portions of the United States are experiencing the highest level of influenza activity several months earlier than we have typically seen since we started influenza surveillance. As you can see, there has been over 880,000 confirmed influenza illnesses, over almost 7,000 hospitalizations, and 360 deaths, all estimated from influenza thus far. Cumulative hospitalization rates are higher in week 42 than in every season since 2009. And 2009, if you will all remember, is when we had the H1N1 influenza worldwide pandemic, and that's why we use that also as a marker. Currently, we have influenza type A, subtype H3N2 circulating as the most prevalent virus this year, and the overwhelming burden seems to be in immunocompromised people, which we will discuss in a moment. And this all comes at the same time we are having surges of RSV and adenovirus. And let us not forget the fact we still have a worldwide pandemic of COVID-19. And that brings me to talk about predictors. Where do we think we are going? Well, here in the United States and really in the Northern Hemisphere, we look to our cousins in the Southern Hemisphere for clues. We have opposite respiratory viral seasonality between the North and the South. And importantly, two places I do want to highlight because we have decent data that we track quite closely. Australia had its worst influenza season in 5 years. Cases were 3 times higher than they were on average historically. And the cases actually peaked 2 months earlier than usual in May and June. They usually will peak later, as we will see in a moment. And cases also started appearing in April. Importantly as well, Chile's influenza positivity rates did reach very high numbers in January that were accompanied by an increase in hospitalizations. And we think of when we think of reasons as to why this may be occurring, well, the lifting of pandemic mitigation measures has been quite telling. For several years, we've had low levels of circulating viruses, not just with influenza, but with other viruses. And because of that, we've had waning exposure and waning immunity over time. So this is a pictorial representation of what I was just describing. On the left, you have the timeframes of when RSV is quite prevalent. In the Northern Hemisphere, it typically reaches its peak when you see that blue arrow. So that is that's January and February. And in the Southern Hemisphere, it typically reaches peaks in July and August. Influenza A, which is on the right side of your screen in the Northern Hemisphere, as we know, reaches its peak in January and February. And you can see all that red that is there throughout the Northern Hemisphere. In the Southern Hemisphere, it's typically in July and August. But as I mentioned, Australia started seeing cases in April and actually started to see its peak in May and June, which is 2 months earlier than we would expect historically these situations to arise. Here are some symptoms of influenza that I think we all know. Fever, cough, pharyngitis, coryza, myalgias, arthralgias, headaches, fatigue. I'm sure we've all experienced some of these symptoms, with COVID-19. I did put asterisks next to the fever and nausea, vomiting, diarrhea, as these can be not only subjective, but also are most common throughout ILIs. What does separate influenza from the common cold is that sometimes it feels to hit us with a freight train, as they say. It comes on very abruptly. It can be very severe. Fever often can last for several days, and respiratory distress can sometimes occur, especially with severe cases. These are all warning signs to, of course, look out for. But influenza itself can also be asymptomatic, which is why it can be quite challenging to diagnose and why it can be quite challenging to treat. People often can experience symptoms 5 days after they are infected, and they also can be contagious sometimes 1 day before they actually display symptoms. Has a much smaller or quicker incubation period than something like COVID-19. But as with COVID-19, people who are immunocompromised, older children, adults, sometimes they can be contagious for much longer and can have prolonged viral shedding periods. Influenza is spread through droplets, although there can be some spread through contaminated fomites or contaminated surfaces themselves. And so that brings me to briefly talk about some management and some management pillars. The important thing here is that early antiviral treatment is essential for benefit to be realized. And we do not wait for laboratory confirmation of influenza, and we start to empirically treat these patients, especially in high-risk groups, as you can see here on the screen, ideally within 48 hours. Early antiviral treatments can shorten the duration of fever. They can reduce the risk of complications. Here in the United States, there are 6 approved drugs, with 4 currently recommended for use during our current influenza season. And I'm just going to briefly talk about them. So influenza A is the predominant type, as I've mentioned, and so we need to keep that in mind. And A viruses, as some of you may know, are divided into subtypes based on 2 surface proteins, hemagglutinin, or the H, and neuraminidase, or the N. So the 3 neuraminidase inhibitors block viral binding as well as virion release. And the classic, as you all know, is oseltamivir, otherwise known as Tamiflu. But we do have 2 others with different routes of administration. They are more challenging to obtain in the United States, and they also do possess some activity against influenza B viruses. The next, in the middle of your screen, is comprised of an endonuclease inhibitor, which interferes with RNA transcription and thus blocks replication. It does have some activity against influenza A and influenza B. Third, the adamantanes target a viral ion channel, and they prevent replication and technically are active against both A and B. However, there are very high levels, greater than 99% of resistance among the circulating subtypes this year, H3N2 and H1N1. So we are not currently recommending these to be employed. The other 2 classes currently have low resistance levels, but as always, this can change, especially in immunocompromised patients who may have prolonged viral replication. Now, I do want to also point out that there is a lack of clinical data in hospitalized patients, so those with severe influenza, in the use of zanamivir and peramivir, as well as baloxavir. So the initiation of oseltamivir is really recommended in patients who have severe cases, as we are still lacking data with the other 3 drugs. And so I just wanted to briefly talk about co-infections because this often comes up. When do we consider bacterial co-infections? Well, this is a very difficult situation in which we find ourselves, and sometimes, very difficult to diagnose. We often want to make sure that we get lower respiratory tract sampling, so either through a BAL that is blind or that is performed under direct visualization. And we also consider bacterial co-infection when patients have severe disease. So when they have extensive pneumonia that sometimes perhaps may be needing mechanical ventilation, or when they have persistent shock, when they deteriorate after an initial period of improvement, or if they fail to improve after a complete trial of antiviral therapy, which typically lasts about 5 days. In these situations, we often recommend the empiric use of antibiotics to cover broad ranges of bacteria that might be found in the respiratory tract. People often raise the question of, well, do corticosteroids help here? And this is a bit of a place in which we have a lack of data as well. What I can tell you is that if someone unfortunately develops ARDS due to influenza, we do know that corticosteroids are indicated for that dysregulated immune response, similar to how they're indicated for ARDS from COVID-19. But for the primary infection itself, we do not recommend the use of corticosteroids. And similarly, for immunomodulating therapies, we are not currently recommending those for adjunctive measures. For more information on this, I would highly recommend checking out the Infectious Disease Society of America, or IDSA, practice guidelines. The most recent update we have is from 2018. But they also discuss more in depth on differential diagnoses that may be non-infectious in origin, in case all therapies in which we are trying are not to be of benefit. And with that, I am going to end there and turn it over to my colleague, Ms. Aileen Patel, for further discussion of influenza vaccination. Thank you.
Thanks, Gavin. So we're going to talk a little bit about influenza vaccines for this season. We sort of broke it down into a who, what, when, where, and why. We'll start with the who on getting flu vaccines. So this is not anything new to this season, but CDC recommends getting a vaccine for anyone aged 6 months or older. And there is a specialized high dose formulation for those patients that are over age 65. There are 3 current options available for that age group as well. And then for anybody higher risk, these groups include kids who are under age 2, over age 50, those who are residents of nursing homes or other long-term care facilities, anyone who's pregnant or is considering getting pregnant or planning to get pregnant during this flu season. And then, as we hear, typically those who have a weakened immune system or a chronic illness are advised to get flu vaccine, as well as anybody with a body mass index or a BMI of over 40. The what? There are two different options available for the flu vaccine in delivery. So there is an IM injection or a nasal spray. Both options are recommended by the CDC depending on your age and your risk. For this flu season, we're doing the same formulation as that which was recommended for the Southern Hemisphere, as Dr. Harris has just discussed, which went from April to October of this year. There are recommendations available on the CDC website for the composition of the flu vaccines themselves. But then one note just on the nasal spray option, it's approved for those who are over age 2 and under age 50. So those aged 2 to 49, if easier and they opt to go this route, that would be instead of choosing the IM route. This is just a little bit of information about vaccine manufacturing and how many doses they expect to have available for this season. You can see 173.5 million to 183.5 million. What I thought was interesting was how much larger it was available during the first year of our pandemic. So the 2021 season was a little bit higher at 194.4 million doses. Regardless, lots and lots of doses available to people this year. So the when, as Dr. Harrison pointed out earlier, most experts believe it's best to do this before the end of October, and that's because it does take about 2 weeks for your body to develop immunity after vaccine. Even if now we're in the first week of November, vaccine is still recommended because it can still help protect you in later months, as we had seen that peak flu activity is usually between December and February, but can continue into May as it did last year. There is still plenty of time to get your patients or yourself vaccinated as soon as possible. And then I know there have been some questions about doing co-administration with flu and COVID vaccines. Perfectly acceptable to get both at the same time. This applies to both adults and for children. If you're in the office, get both vaccines while you're there. People, the only side effects, the side note to this is that people who did receive the flu vaccine at the same time as their mRNA COVID vaccine booster had a higher rate of some reactions. So 8 to 11% had fatigue, headache, and muscle ache, but mostly these reactions, as seen in the most recent studies, were mild and resolved quickly. So this is sort of a where and a why. This is the same picture that we just saw Dr. Harris had up. It is already here. It's already circling around the country and making its way north. And according to FluView, you can see that the most frequent reported virus at this time, as we had heard previously, was influenza A, and that's the H3N2. So it is out there. Now, as for the why do we need a flu vaccine? Flu causes as many as 50,000 deaths annually, but many more hospitalizations. Our little pyramid here goes through illness versus hospitalization versus death, but definitely has a high burden every year. The flu vaccine can lower your risk of getting the flu, but also can lower your risk of having a serious illness from the flu, which would potentially require hospitalization. And the more important part, I think, of this is that remembering last year's flu vaccine may not protect you from this year's viruses that are circulating. So every year a new flu vaccine formulation is released, and this is to help keep up with the rapidly changing viruses that are seen as based on what's going on in the Southern Hemisphere. I know there was a question earlier about the effectiveness of seasonal flu vaccines, the research that has come out shows that it is approximately just shy of 50% effective every year, depending on the viruses and what they've made their composition each year. This only goes back to 2009, and we don't have great data, obviously, because of COVID and such the low numbers during the 2020-2021 flu season. But last year's flu vaccine was about 35% effective. We won't have data on this current year's until the end of the season or later. So we won't have answers on that quite yet. Regardless, it works. Thanks so much. I'll pass it over to Anna.
Thank you, Aileen. Hello, my name is Anna Yaffe, and I'm going to be discussing some specifics, things to think about as frontline providers. So a bit of an overview of the next several minutes. So as we've heard from our previous two presenters, we know that there is a ongoing respiratory virus surge, and we have a risk to see an even greater surge in the coming months. So I know as a frontline provider myself, we're all really tired of respiratory viruses, but we still need to be prepared for influenza as well as other all hazards threats. And I think by using some very basic preparedness mantras like identify and isolate, we can really prepare ourselves, our patients, and our emergency department to be ready for whatever comes through our doors, and also enable us to continue to care for our patients in an all hazards way. Of course, the best thing we can do is prevent spread of influenza in our communities and within our emergency departments ourselves, and we'll talk about that in the next several slides. So when we say identify, this is something that you probably have been hearing over the last few years as we've talked about COVID and other special pathogens like viral hemorrhagic fevers like Ebola. But we can also use our universal symptom and travel screen to identify more common viruses like influenza. And so a lot of you may already be doing something similar like a universal symptom and travel screen in your facility. But if not, this is a good first step to help you identify a potential contagious or infectious patient. So first, we ask if there are any symptoms. So this is an example of a symptom screen, but yours may be slightly different. But the kind of very common infectious symptoms like cough, fever, and maybe some GI symptoms are important to include. And those are going to start to clue you into the fact that a patient may have something infectious that you do not want spreading in your waiting room, to your healthcare providers, or in your emergency department. We include the travel screen next as a way to identify patients who may be at risk for having a more special pathogen, something that is in a localized outbreak, something like, for example, right now we have Ebola in Uganda. But we can also use this time when we ask patients about travel to ask patients about other exposures. So if they do have a symptom of an infectious disease, potentially at that time, we can be asking about exposure to others who are sick contacts, or maybe more local travel or large event exposure, things that would clue us into the fact that this patient could be at risk. So why do we use this as more of a universal concept? So for me, as a frontline provider, I want to be identifying all hazards threats. So this may be something serious like MERS, SARS, Ebola, something like very unusual and rare, but hazardous. But we also want to identify all those regular infectious diseases, COVID-19, influenza, even things like measles, things that we may not see every day, but are a potential to walk through our emergency department doors, because we want to identify them to prevent further spread. So when we identify a patient with a potential infectious symptoms, this can facilitate a patient's isolation. So we want to prevent our waiting room and our emergency department spread, and then also prevent spread to our healthcare workers. So the next I is isolation. So we want to think about the type of transmission, the pathogens that we're concerned for that the patient may have would be spread by. So I think I like this infographic because it really helps to kind of demonstrate what types of transmission different pathogens have. And for influenza, we're thinking about droplet transmission. So these are things spread by large respiratory droplets to susceptible individuals, but can also be spread through direct and indirect contact with things that have contacted those droplets. And when we think about this type of transmission route, we can think about our isolation precautions, our PPE, things that my colleagues are going to discuss in more detail. So some basic steps to isolate your patient when they present through your doors. The first thing, hopefully we're all doing this already, but mask anybody with symptoms. In my emergency department, we're still masking everybody. So this is kind of already taken care of for us. But sometimes maybe we've kind of gotten away from some of the masking. So if a patient endorses any infectious symptom, it's important to put them in a mask. That's going to be the first line barrier to protect yourself, your staff, other patients. We can then start thinking about maybe a split triage flow. So this is something that some of us started doing during COVID, where we actually have 2 separate spaces for patients who have infectious symptoms and patients who do not. So to prevent spread within our waiting room. If we get into an influenza surge scenario, which Dr. Harris mentioned is a possibility this year, we can think about actually sort of offloading some of our lower risk patients. So this emergency department risk stratification tool is an example of something that was developed based on previous pandemic influenza and then adapted during COVID. But basically, we think about patients' risk level based on their symptom severity, based on their comorbidities, and then kind of what kind of treatments, what kind of care they need, and where the next steps are to hopefully potentially remove some of those lower risk patients out of the emergency department so they're not spreading disease to other patients or staff, and also are able to get equivalent care. So these are patients that are sometimes thought of referring to a primary care or using an information hotline like maybe had been set up during COVID to help kind of get patients the care they need. The intermediate risk patients can go into the ED. They kind of consider being tested for the pathogen. And then of course, high risk patients may need a more critical care area. Once we identify these patients, we want to keep the patients in the waiting room to a minimum. So as much as we can, and I know we're seeing huge surges right now, and it's hard to offload our waiting room, but as much as we can get potentially infectious patients out of the waiting room and into a room, ideally with a door, that is the best way to prevent further ED spread. And then for healthcare workers in particular, thinking about using the appropriate transmission-based personal protective equipment and isolation precautions. And again, my colleagues are going to discuss that in more detail. So you've gotten your patient identified, you've isolated them into a treatment space. Now what? So of course, our next steps are taking care of our patient. So we want to provide this patient whatever they need. So that may be supportive care, that may be an antiviral like Dr. Harris discussed, that may be influenza testing and co-infection testing. So right now, for example, any patient who's presenting with respiratory symptoms at my facility is getting tested for influenza as well as COVID-19 and RSV. But additional patients who may be immunocompromised, may have other comorbidities, may qualify for more expanded respiratory viral testing and bacterial co-infection testing. So just kind of depending on the needs of the patient. But I think it is helpful to guide further treatment and management to know the delineation between influenza, COVID-19, co-infections, and other viruses and bacteria. We also want to identify and manage other concomitant processes. So sometimes these patients may also have a cardiac disease, bacterial disease, other types of sepsis, other things that maybe are not infectious. So we want to be sure that we are working up our patient for everything that is a potential risk for them and not just kind of becoming tunnel vision on influenza or COVID. And then the other thing to think about is prevention of kind of further spread at a baseline in your emergency department. So we heard about the importance of flu vaccination already, but it is really important to encourage healthcare workers in your facilities to be both up to date on their influenza and their COVID-19 vaccine to protect them, but also to protect patients. Additionally, I think offering influenza vaccination in the emergency department is a really good idea for your patients, because sometimes the emergency department is really the only point of contact with healthcare that patients have. So while you're there, capturing that opportunity to vaccinate patients is really easy. There's often nursing-driven, electronic medical record-based approaches to help identify and target patients who are unvaccinated for COVID and for flu. And so that's an easy way to capture those patients and get them taken care of from that way. And then also healthcare worker masking. I know that we're really tired of wearing masks at a baseline, but I think now is not the time for healthcare workers in the emergency departments and other frontline facilities to become a little bit complicit in this masking. I think that right now, during our height of our respiratory risk of height of respiratory pathogen spread, that we should be wearing our masks for every patient, because we just ultimately can't know who's asymptomatic, who's at risk for ourselves. And the best way we can take care of our patients is to take care of ourselves. And finally, I just want to put a quick plug in. I know that we are all so tired at the front line of kind of the last several years of surge and shortage and being overworked. But I just want to remind everybody in the front line that you're not alone. So I know that these times of surge can be a really big stressor, and it can cause burnout, have a decrease in provider wellness. And so I think that kind of talking with your administration, talking with the other providers, the staff of your emergency departments, your frontline facilities, to make sure that you are taking care of each other's wellness, taking care of each other in all ways is really important. I think some of the things that can help this is fostering fellowship, fostering open lines of communication amongst each other and amongst your administration, and then having a strong advocate at the system level to be sure that you have the resources that you need to take care of your patients and to take care of yourselves. I think with that, I'm going to turn it over to my colleagues, Trish and Jill, to talk about infection prevention.
Hi, everybody. I'm Trish Tennell again, and I'm from H&H Bellevue. Thanks, Anna. And that was great. And I just wanted to say, you're going to hear maybe some things that are a little bit redundant, but we really want to drive the point home. So let's talk about just basic infection prevention control for influenza. When you're dealing with the flu, the best defense is going to be a super strong offense. And that means get your vaccination. Please use hand hygiene. Anytime you may touch a patient, a piece of equipment, you're taking off PPE, or just in general, hand hygiene. And don't forget your fingertips. And remember, it's friction that works with hand hygiene, alcohol-based hand sanitizers, not flapping your hands and hoping it dries that way. Make sure you're wearing the appropriate PPE. And my colleague, Jill, will tell you a little bit more about that. And not only are you wearing it, that you're wearing it correctly. And then physical distancing. Gavin mentioned, that we were seeing a lot of high outpatient visits. So you want to make sure that your patients have some space that they're able to physically or social distance, or you're able to physically or social distance from them. Remember, you can be contagious before you're symptomatic. So you really want to make sure you have this space. And self-identification. Make sure a patient, just with identify, isolate, and inform, is able to self-identify. I've had a fever, a runny nose, and I don't feel well. Make sure they're able to self-identify, wear a mask. Make sure you get signage up there. So we're going to talk a little bit about respiratory etiquette. I talked a little about hand hygiene and triage. Signage is so important. Make sure you post signs or posters at every point of entry in your hospital. It could be the cafeteria. It could be the coffee shop on the first floor. It could be you're walking into an ambulatory care setting, in your MRIs, in your radiology departments. Make sure you have signage, and signage with either pictograms or inappropriate languages. I know we have over 30 languages that we're able to translate signs in. And show people, make sure you use a tissue. Make sure you sneeze into your celadon, which is going to be your new favorite word today. Google it. Or they have the ability to mask, and you have alcohol-based hand sanitizer or places for people to hand wash. Make sure there's waste receptacles that they can throw waste in so it's not laying around. And again, have signs up to help people learn how to do the correct hand hygiene. Here's a self-recognizing station. It provides masks, it provides hand hygiene, it has tissues on it. People are able to use it. If you don't have it accessible, we know people aren't going to use it. Teach people about respiratory etiquette. That includes your colleagues. Some people may be new. I'd like to turn it over to Jill next. Jill?
Thanks, Trish. Yeah, I think a lot of us thought that the term respiratory etiquette was pretty well understood, but it's sometimes not, especially by the general public who may not be clear on what all is covered by respiratory etiquette. So reinforcing what you're expecting of visitors, patients, and staff is really helpful. So as we've talked several times today, this early identification really empowers healthcare systems and healthcare employees to make a safer environment. So identifying people at the point of check-in, on arrival, about any symptoms they might have, and then providing them with directions, clear directions on what you want them to do, whether that's putting on a mask, whether that's moving to a designated portion of your waiting area where you've put in some other controls. You want to give clear and simple directions to people. This early isolation, whenever it's possible, is really helpful in reducing the transmission that can occur in busy waiting rooms, hallways, elevators, and things like that. So placing symptomatic patients in a separate area when possible, making sure that you've discussed where that area should be with your facilities engineers so you know where your air intakes are, where your fresh air supply is coming from, and so that you're using good decision making about where these sites should be. And then administrative methods in that hierarchy of controls that tell us and guide us towards things like how frequently that space should be cleaned, making sure furniture in these places are wipeable, refilling the supplies in those stations like Trish was talking about, and then emptying trash and things like that, making sure that people have the things they need. And during periods of really high influenza or other ILI activity, consider whether you are better served by a step even before people enter your facility by setting up triage or testing stations that allow people to be screened before they walk into your facility where they might encounter or increase the risk to some of the other patients that we have within the hospital that we know are at high risk for complications from these infectious pathogens. So what is the PPE for influenza? Well, let's first talk about the fact that flu season is a great opportunity for us to step back and review both the usage and the compliance to PPE most of us have been using solidly for the last 2 years. We haven't always developed great habits, so looking at yourself and your own behavior and that of your coworkers, are you making sure you're doing things like hand hygiene after you remove your mask or respirator or your eye protection? Are you disposing of masks after you've taken them off? You know, we are hopefully at a point where we will not have the supply shortages that we've had in the past, but knowing what your hospital's policy is on how long you can reuse a mask or respirator is important. You want to avoid touching your eyes, nose, and mouth. As we've mentioned several times today, this is primarily spread by droplets, but we do know that contaminated items around a patient. So for instance, if they've been coughing or breathing against things, they might have contamination on their gown, on their bed rails, on things that you might have to touch. And then we want to make sure that you're performing hand hygiene before you carry those pathogens into your own eyes, nose, or mouth. If you're wearing a respirator, a tight-fitting respirator that is, you want to make sure you do a user seal check each and every time you put on that respirator and go into a patient room. So standard influenza PPE calls for standard and droplet precautions, and those can vary slightly by facility. Generally speaking, it's a surgical mask, gloves with eye protection. Some facilities do add a gown. Aerosol generating procedures should require both respiratory and eye protection. So that means upping your game from a mask to a respirator for any aerosol generating procedures, and always making sure you have good eye protection on. And I'm going to say it again, I feel like a broken record sometimes, but healthcare facilities should be conducting fit testing again. That means that if you haven't been fit tested in the last year, you need to make sure that you get that done. And anytime you've had a change to your face or had surgery or anything else that might have affected the way a respirator fits on you, and that is still not a substitute for performing your own user seal check every time you put one on. We've got a bunch of resources that are going to be here at the end of our presentation, but we would also like to address some of the questions that came up as we were speaking, and also that some of you submitted beforehand when you're doing a registration. So happy to turn it back over to Trish and open it up for some questions.
Hi. So I know this has been answered, but I've had 3 thumbs up, so I really think it's important. And Gavin, you answered that, and I just want to let the rest of the participants hear. So the question was, could you talk about asymptomatic RSV? CDC says to isolate for the duration of the illness. We test all admissions with the multiplex biofire, and patients often result positive for RSV. For acute care hospitals, is it recommended to isolate regardless if there's signs or symptoms?
Yeah, thanks, Trish. And I did put a message, but I think it's very important to reiterate as well that yes, we do recommend that for several reasons. And one of the things is that we know with all these viruses, with influenza, with COVID, with RSV, that people can actually become positive and can be infectious or contagious before they show symptoms. And sometimes it may take a little bit longer, depending on the type of virus, to actually develop those symptoms. So we may be catching it early when they arrive in the hospital, which is a good thing. But this does not mean that they may not develop symptoms later, which could cause problems if they are not isolated. And the other reason is that if there are immunocompromised patients, they can have prolonged times in which they actually may be able to spread this virus, even after their symptoms resolve. And sometimes this can last for several weeks.
Thank you so much, Gavin. And I don't want to catch you off guard, Anna, but I want to ask you this question. Are there alternate antibacterials for secondary infections like pneumonia with the shortage now of amoxicillin and Zithromax?
Yeah, so there are a variety of antibiotics, and I know we've been struggling with some shortages of different medications throughout the last several years. So what I would recommend is actually kind of looking at the your own antibiograms in your location, at your facility, to know kind of the susceptibilities of common circulating bacteria, and then kind of directing your alternate antibiotic choice towards that antibiogram.
Thanks, Anna. And the next one's for you, Aileen, and it's kind of a combination between a question you've already answered and a question that was proposed when people registered. The question that you already answered is there still a recommendation for elderly folks to have 2 shots flu vaccines? And if so, how far apart? And then people asked, is there any other guidance to receiving a second influenza vaccine 90 days after the first dose?
Thank you for that. Yep, I was actually just looking again to confirm that I'm giving the correct information, but outside of children who are, I actually think it says under 6 months, I will confirm that, but besides children that are getting their flu vaccine for the first time and they need to get a series of it, there is no indication they don't to repeat a second dose within the same flu season. Their studies have shown that there's no benefit in doing so. So 1 shot for the season and then start again next year.
Great. I have yet to get my flu vaccine. Guess what I'm doing after this webinar? Okay. So Gavin, I know you answered this question, but I thought it was interesting and I'd like to hear more about it. The bird avian flu activity and transmission has transmission to humans as well as human transmission. So can you just talk a little bit about that to us?
Yeah, sure. So we know that, avian influenza A viruses are circulating quite heavily actually right now throughout the world in poultry and other wild birds too. We haven't really seen transmission to humans yet on a large scale. There have been a few cases of highly pathogenic avian influenza in the United States, but it's extremely rare as of now. And I also want to point out too that the terms highly pathogenic avian influenza or low pathogenic avian influenza refer to the mortality in birds in actually experimentally infected birds and not to the mortality that can be expected in humans. And so this is a common misconception, with the caveat, though, that something like highly pathogenic avian influenza is right now considered a special pathogen because we don't yet have effective medical countermeasures and we don't know how our current therapeutics may work. But these terms are extremely confusing. So the long story short is it is circulating in birds right now. It is not really spilling over into humans at this time, but we are monitoring it closely.
Thank you. And I'm going to try to slip one last question in, and I kind of want Aileen and Gavin both to add to this. Are there mRNA flu vaccines in development, and when will they be available? And do you know anything about the effectiveness? Gavin, I see you started.
Sure, I'm happy to go. I do know that Pfizer has just started a phase 3 clinical trial, or maybe a month ago, of an mRNA platform-based flu vaccine. I think the first adults have been dosed with that. I am not aware of the effectiveness of it. Aileen may know, and I'm also not aware of when it may be, deployed. I would not expect to see mRNA vaccine deployment this flu season, although that could certainly change, I think, depending on how this goes. But Aileen may know more than I do.
Unfortunately not. Actually, I was reading your comment and going to look that up. So I apologize that I didn't look into that. And I was fascinated also by the option of a potential flu plus COVID vaccine in the future. So I'm going to do my own research on that.
And that's great, because this will open me up to tell what. Sorry, Jill.
I'm just going to say today is a great day to get your vaccines, because with 2 weeks lead time, you will be in good shape for family gatherings at Thanksgiving. So please, Trish and everyone else, if you haven't been vaccinated, we need a healthier community and workforce. So please really think about getting your vaccine if you haven't done it yet. Thanks.
Mm-hmm. And I guess I am going to see, and I see somebody answered on public transportation. I take public transportation every day on a very crowded train. And I make sure I hand hygiene before I get on the train, because I'm always grabbing the rails, and I make sure I wear my mask. And I'm also very cautious, especially from riding on the train, that when I get outside, before I take off my mask, I hand hygiene again. So I have the cleanest, most possible hands that are going up near my face. So yes, I will always wear a mask on public transit. I recommend it for anybody. All right. So I think we're going to conclude here, but I also want to say really quick, because you'll get a little bit more. Any questions that we haven't answered, we will answer. Please get it to us here. You can put it, or contact us at info@netec.org. I have a feeling there's going to be a couple more questions about the mRNA vaccine, and I know we all want to learn more about that. Remember, we're here to help. We continue to build resources, and the way we build these resources are questions and answers from you guys, what you guys want to see. So again, send your question at info@netec.org. They'll be answered by the appropriate NETEC SMEs. Also, you can submit a technical assistance request. If you want us to assess your space, some of your protocols, send it to us at netec.org. Remember, we have courses and e-learning at netec.org. We have podcast Transmission Interrupted. It's on all major podcast players. And we have skills videos that are on YouTube at youtube.com/thenetec. We're on Facebook, Twitter. We have a blog. We're on Instagram, and we're also on LinkedIn. Use the hashtag NETEC. We have our own website. We have a resource library, and we are able to answer our emails through info@netec.org. I want everybody to be safe. I want you to have a happy Thanksgiving. I want you to get your flu shot, and remember to wash your hands. Have a good day. Bye, everybody.